hello again, welcome. My name is Michael Boniface. I'm one of the instructors in emergency medicine in the Department of Emergency Medicine at Mayo Clinic, Florida, and also serve as the director of emergency ultrasound. Today we're going to be continuing our series on an introduction to bedside ultrasound, talking about clinical bedside echocardiography. We're going to talk about some of the indications for these studies, the different mechanics and image acquisition techniques, and some of the clinical questions that you can be answering in your daily practice. So, first of all, why is this important? Well, it helps save time in the emergency department, on the floor, in the intensive care unit setting. It will improve diagnostic uncertainty, particularly when it comes to undifferentiated dyspnea, shock states, and volume status. It can help guide resuscitation. At Mayo Clinic, Florida here, we're now bundling this into our SSRT, or Septic Shock Response Team package. And the other thing is that, although it can be somewhat daunting, it really doesn't take that much practice to get comfortable answering some of the basic questions we're going to go over. So in this talk, we're going to be discussing the different imaging windows and acquisition techniques, some brief assessment of left ventricular systolic function, determination for the presence or absence of pericardial effusion if there is clinical concern for tamponade physiology, signs of right ventricular overload, and a brief discussion of the inferior vena cava. So why are we going to want to do a limited echo at the bedside? Well, really any patient presenting with new dyspnea, suspected heart failure, undifferentiated hypotension or other shock states, or in sepsis, it's good both to get a baseline to either confirm your diagnostic clinical suspicion or to help guide the next steps moving forward. So first thing is going to be selecting which transducer we're going to use, and we're going to want the phased array transducer. This is what's commonly referred to as the cardiac probe. Notice that there is the indicator on the handle, which will always correspond to the blue dot on the screen. And when you begin a new patient examination, you're going to want to ensure that you're scanning in the cardiac mode exam type. So here you can see that under type, it's selected as abdomen, which is an option even for the phased array probe, but by changing that in the drop-down menu, you want to ensure that you're on the cardiac examination subtype. And I'll show you why that matters in the next slide here. Here we have two patients, both with pericardial effusions. One is being seen on the left in the subxiphoid view, and the other is in the parasternal view. But if you look at the top right-hand corner here, these are both being recorded with the phased array transducer, but one is in the abdominal exam type and one is in the cardiac subtype. You can see how the cardiac one on the right looks like it's much more fluid in its motion. So it's kind of the difference between looking at a football game on an old television versus one of these new 240 hertz, live motion type cameras, because it actually is recording at a much higher frame rate per second in the cardiac subtype than you are in the abdominal subtype. It also does a couple other things like turning off multi-beam imaging, and that's my cat. Alright, thank you. Moving on. So, talking about the basic echo windows for normal anatomy, we're going to start with the subxiphoid or subcostal view, the parasternal long axis, parasternal short axis, the apical 4 or 5 chamber view, and finally the inferior vena cava. So I like to start my examination with the parasternal axis view. This is going to be oriented with the long axis of the transducer beam aligned parallel to the long axis of the heart. So we're going to start to the left of the sternum, probably in about the 4th or 5th intercostal space, with the indicator pointed towards the 10 o'clock position or towards the patient's right shoulder. Now, everybody's heart is going to be lying in a slightly different axis, so you may need to adjust your probe orientation slightly clockwise or counterclockwise, depending on how the heart lies in their chest. But you want to rotate until you see the heart in its longest axis possible, and that will be your baseline for the parasternal long. From there, the parasternal short axis is the exact same imaging window with your transducer, but you want to rotate the probe 90 degrees clockwise such that it's pointed towards the patient's left shoulder. Our apical view, we're going to place the transducer where we feel the PMI on physical examination, usually just below the left nipple or inframammary crease. And the subxiphoid and IVC views obviously are going to be placed right below the xiphoid process, and in most cases will be slightly to the right of midline, so that we can use the liver as an acoustic window seen into the heart, as to avoid scatter from gaseous distension of the stomach and small bowel. So although there is primarily just one type of view we're looking at in the parasternal long axis, it's important to realize that in the short axis, when you're 90 degrees clockwise as a cross-section through the heart, you can view this in several different imaging planes. So in the middle, we're actually going to cut it as a cross-section through the mitral valve, but if we go slightly more apically, we'll cut it as a cross-section through the papillary muscles, or if we go slightly more towards the base of the heart, we'll actually see the aorta. Thank you. It's my wife's cat, not mine. All right, here's an example of the parasternal long axis view of the heart. We can see it's nice and fluid. Our depth is set to about 13 centimeters in this patient, who's a very trim guy. I'm going to point out some structures that you'll see here, starting with the left ventricular chamber. The right ventricle is actually the first structure that the ultrasound is going to go towards. The left atrium, the aorta, the descending thoracic aorta, and that bright white stripe is the pericardium. Now, if you don't see the descending thoracic aorta, your depth is not set quite deep enough. It's important to see that structure, not only in the rare circumstance that there's going to be an aneurysm or dissection flap, but also in the presence of pericardial or pleural fluid. Seeing its relationship of the free fluid to the descending thoracic aorta will help us determine which space it's actually in. What I haven't pointed out here in these slides is obviously you can see two of the heart valves. Since we see the left atrium, left ventricle, and aorta, we can see both the mitral valve and the aortic valve. Rotating your probe 90 degrees clockwise will produce this parasternal short image of the heart. This is a cross-section through the left and right ventricle. The left ventricle is a higher pressure system with a much thicker, more muscular wall, so it retains a very circular shape, and adjacent to it, on the other side of the septum, we see the sort of V-shaped right ventricle, as is its normal relationship. Now notice that in the beginning of this clip, when it recycles, right here, we're seeing the mitral valve opening and closing, and that's sometimes referred to as the fish mouth. But as I reposition the probe and point it slightly more towards the apex, we see the papillary muscles at 4 and 8 o'clock. So fish mouth of the mitral valve, and apically, boom, papillary muscles at 4 and 8 o'clock. For some of the measurements we're going to be talking about later, we actually want to have it at the plane through the papillary muscles, not the mitral valve. And so here we see, again, left ventricle cavity, right ventricle, papillary muscles there. The muscular wall of the left ventricle between those two chambers is obviously representative of the septum. And this is a representation of what the different short axis views will look like at different planes, as we saw in the prior diagram. So in the top left, we have the mitral valve open during diastole. Adjacent to that is the papillary muscles. In the bottom left, we have the probe pointed much more towards the base of the heart, and we're actually getting a cross-section of the aortic valve during systole, where you can actually measure the valve area. In this case, it's over 2 centimeters squared because it's a normal, young, healthy patient. Next imaging window is the subcostal or subxiphoid view of the heart. This is going to go just underneath the xiphoid process, typically a little bit more towards the patient's right, so that you're using the liver as an acoustic window, meaning something that the sound waves can transmit through in a good fashion, so they don't hit the air in the stomach or the duodenum. And the very first thing that we'll see after the liver is going to be the right ventricle, right? Because that's what the base of the heart sits on the diaphragm. So we see the right ventricle on top, which means that the left ventricle must be the other one, and both of their corresponding atria. Now, this is nice because in most cases we can get a relatively good 4-chamber representation of the heart, which is a lot easier to obtain in most cases than the traditional apical view. You can't do some of the other more advanced quantification functions or Doppler studies that you can. And finally, the apical 4-chamber view, which has both the left and right ventricles, as well as their corresponding atria. This is aligned in a manner such that if you wanted to do Doppler studies, you are now completely parallel to the AV valve inflows, and so you can get accurate velocities on spectral Doppler. Now here is a point where Mayo Cardiology actually does it differently than most of the rest of the world. So in the image you're seeing here, the left ventricle is actually going to be on the right side of the screen, the right ventricle on this side, and their corresponding atria. Most of the Mayo Cardiology department here actually does this as a mirror image. If you ever are confused, the ways to tell the left ventricle between the right ventricle are usually pretty easy. In a normal healthy heart, the left ventricle is always going to be bigger. It's a relationship of about 0.6 to 1 of the right ventricle to left ventricle. Now, careful, in patients who have chronically elevated pulmonary pressures or have an acute pulmonary embolism, that right ventricle will be pathologically enlarged, and so they might be the same size. But generally speaking, the left ventricle is going to be larger. Additionally, if you fan your probe up just a little bit, you can create the apical 5-chamber view where you see the left ventricular outflow tract, and obviously that corresponds to the left ventricle rather than the right ventricle. And finally, the tricuspid valve is always going to be a couple millimeters more apical than the mitral valve to help differentiate the right from left ventricle. And finally, the inferior vena cava view. Here we see it traversing the liver and the first hepatic vein just before it crosses the diaphragm into the right atrium of the heart. All right. Best applications, it really depends on the clinical question you're trying to answer. If I just want to get a very brief estimation for function and presence or absence of effusion, the subcostal or subxiphoid view is usually the easiest. This is the preferred method that we learned in our FAST examination last month. Parasternal long axis, this is also a really great representation both for function and presence or absence of fluid. Parasternal short axis, I prefer this for looking at the relationship of the right ventricle to left ventricle because you can sometimes get a deformation of the septum bowing into the left ventricle in elevated right systolic pressures. You can see focal wall motion abnormalities of the left ventricle wall segments, and you can also use some estimative quantitative functions in this short axis view. Apical 4 and 5 chambers where you can really do a lot of your more advanced applications, such as looking at diastolic inflow across the valves, quantifying excuse me, VTI through the left ventricular outflow tract, seeing a great relationship of the size of the left and right ventricle. So it depends on what question you're trying to answer. And inferior vena cava, obviously, we're using as a surrogate measure for preload and volume status, which we'll get to in a little bit. Okay, so right into assessing left ventricular systolic function. Here we have a parasternal long axis view of the heart in 3 different patients. And the first method of assessing left ventricular systolic function is just the clinical gestalt, is looking at the left ventricle, seeing how well it squeezes, and saying, does this look normal? Does this look a little reduced? Or does this look markedly reduced? And that's what these 3 images here represent. So from the top left, we have a normal ejection fraction, probably greater than 55%. Top left, it's probably a little reduced, I'd say around, 40% or so. And in the bottom, we've got a markedly reduced ejection fraction, probably around 15% or so. So here are those same 3 patients, now represented in the apical 4-chamber view. Again, top left, normal ejection fraction. Top right, slightly reduced. Bottom clip, barely moving. And you can see pretty easily between the difference of them. There's one example that I didn't talk of, which is the hyperdynamic heart, which has an ejection fraction greater than 65% or so. This is what you'll see in most cases of compensation for distributive and other shock states in a healthy heart. All right, so to actually calculate the left ventricular systolic function, that's usually what everybody's really excited to learn how to do. I want to go to the bedside, put the probe on, and tell you exactly what the EF is. And what I want you to take away from this lecture is that you don't need to get that precise. You're not an echocardiographer. You're not a cardiologist. I don't need you to tell me that the ejection fraction is 27.5%. The cat again. I do want you to tell me whether it is squeezing normally, whether it is squeezing not quite as well, or whether it is markedly reduced. You really just need to classify it into those three areas, and you're going to be pretty far ahead of the game. Now, to calculate the left ventricular ejection fraction, you could provide all of these measurements and plug in some calculations, but there are some shortcuts that I want to show you here. So E-point septal separation is one quick estimate that you can use. So basically the concept behind this is that since the cardiac output is a function dependent on the diastolic inflow, so preload, afterload, you're going to see a relationship of the anterior leaflet of the mitral valve during diastolic filling. So if we use our M-mode spike through the right ventricle, septum, mitral valve's left ventricle, we'll see this relationship here, this little spike of the mitral valve going across. And basically, if we measure the mitral valve anterior leaflet comes within about 6 or 7 millimeters of the septal wall, you can safely say that the ejection fraction is greater than 50%. If it does not, if it's greater than 12 millimeters, then the ejection fraction is likely less than 35%. Now, this has some limitations, obviously, in patients who have abnormalities of the mitral valve, if it's stenotic, if the heart is very dilated but still squeezing well. It's not a perfect measure, but in most cases you can get a general assumption of the ejection fraction by looking at that mitral valve leaflet. So here in these two examples we see a normal E-point septal separation in the top left and an abnormal in the bottom left, where it is coming within about 2.6 millimeters in the normal heart and then 19 millimeters in the abnormal heart. Next method is called fractional shortening. So this basically asks the question of by how much does the left ventricular cavity change between the systolic and diastolic phases. It's not to be confused with the ejection fraction itself, but if you multiply it by 100, it'll give you a rough estimation of so. And it's a lot easier than it sounds. This can be done in the short or long axis, and what you're going to want to do is put an M-mode spike through the ventricle at the level of the papillary muscles. Again, looking at M-mode, and it will give you a representation something like this. So you can see the systolic and diastolic contractions and how that left ventricular diameter changes between the two. This is a function built into the ultrasound machines in the calculator menu. And it will show you here in the normal heart, our left ventricular diastolic diameter is 3.38 centimeters, which reduces to 2.29 centimeters during systole, giving us an estimated ejection fraction of 62%. In the reduced systolic function on the right example, we've got a very dilated ventricle that is 5.8 centimeters, and it only decreases to 5.2 centimeters during systole, which would give us our ejection fraction of 22%. Now, this is a highly inaccurate method of doing so, but again, if you just want something to reassure your clinical assessment and gross estimation by visually looking at the function, this is a very quick and dirty way to do it. When you want to get into more accurate methods of getting a left ventricular ejection fraction, what I like to do is called the Simpson's method or area of discs. The way you do this is in an apical 4-chamber or apical 2-chamber view of the left ventricle, depending on whether or not there are any fixed wall motion abnormalities. You're actually going to trace along the endocardial border with the cursor on the ultrasound. This does take some assumptions into account regarding the shape of the ventricle, but if you do this both in the systolic and diastolic phase, it will calculate a volume for you, and the difference of that, of course, is going to be your ejection fraction. So, pericardial effusion, next thing up. Obviously, I think everybody can see here that there's a very large effusion around the heart, but the question is, does this represent tamponade? And the other thing I want you to recognize is that tamponade here is going to be a physiological and clinical diagnosis. The presence of pericardial fluid does not itself make tamponade, even when it is very large volume, as it is in this case. So this was a young gentleman I was taking care of that had a very advanced scleroderma, pulmonary hypertension, right ventricular hypertrophy, and compensatory pericardial effusion. He actually has a pleural effusion as well. You can see the fluid on both sides of the pericardium there. But does he have tamponade? Well, no, because look at the right ventricle. It's actually not really contracting at all because the right pressures are so high. What happens in tamponade in the first sign, and we'll talk about in a little bit, is collapse or paradoxical wall motion of the right atrial and right ventricular free walls. Because the pressure within the pericardial space will exceed those pressures inside the chambers of the right side. So this is a large effusion. This is representative of alternans because we can see the heart bouncing back and forth, but this is not tamponade. Now here is another effusion. This was my patient at the trauma center last year, a prisoner who was shanked with a shiv or shivved with a shank, and he is coming in with this effusion seen in the subcostal view, and this does represent acute pericardial tamponade because we can see here that the right ventricle, which is, remember, the first chamber that we'll see on the other side of the diaphragm, is barely opening during diastole. This illustrates that the bigger determinant of whether somebody will experience clinical pericardial tamponade is not necessarily the volume of the pericardial effusion, but rather the rate of accumulation. The pericardium has the ability to stretch and expand over time, but it takes time to do that. You can have 600-700 cc's of fluid in the pericardium, and if it accumulates over months, it will expand to be able to accommodate that. But if you get even 100 cc's of blood acutely, then it will not be able to stretch, and you'll overwhelm the pressures of the right side of the heart. Here's another patient that we were seeing here. This is a malignant pericardial effusion, very large. This did accumulate over a long period of time, but at some point the pericardium just can't stretch anymore. And we definitely see collapse of the right side of the heart in this kind of apical view that we're seeing. It's not always that easy. Here's another example where the right ventricular collapse is more subtle, but you can still see it. This is a parasternal long axis view of the heart, and right there in the middle we see collapse of the right ventricular free wall. Other sonographic signs of pericardial tamponade include a plethoric IVC with very little collapsibility with respiratory variation. That, of course, is because the pressures within the pericardial space are so high that it's actually backing up. Alternans, as mentioned earlier, does not represent tamponade. It just means that there's a large volume and the heart is mobile within the pericardial space. You can do some additional calculations, such as mitral valve or tricuspid valve inflow velocity variability greater than 25%, and this is the echocardiographic equivalent of pulsus paradoxus. This is an example of what that would look like over time. There's always going to be some respiratory variation of the diastolic inflow velocities across the AV valves, but we see it significantly exaggerated in states of pericardial tamponade. All right, inferior vena cava. This may be visualized in the sagittal or coronal plane. You typically want to be looking at it sagittally if you can, because it is not perfectly circular. It's sort of lens-shaped, so if you're looking at it coronally, your measurements may not be accurate. But you ideally want to see the first hepatic vein and the right atrium to confirm that what you're looking at is in fact the IVC and not the aorta, is the common pitfall. It can be extremely helpful in estimates of volume status and fluid responsiveness, but it's not the end-all be-all that everybody thought it would be when the research first started coming out. So we do know, however, that IVC diameter and the degree of collapse does correlate with volume states in shock and more, and that it may actually be a better predictor of shock than other vital signs or laboratory studies. It can predict heart failure pretty well, but it's much more useful, I found, at its extremes. And it has very many limitations. Again, people who are on positive pressure ventilation, people who have tricuspid regurgitation, pulmonary hypertension, a variety of other factors that are going to limit its usefulness, but it's a good starting place. So this is what a normal inferior vena cava is going to look like. We've got a IVC here traversing the liver. We see the first hepatic vein and going into the right atrium. It's going to be about 2 centimeters and have a respiratory variability of about 50% or so. There is some evidence to suggest that the size and the percent collapse of the IVC can be used as a surrogate marker for right atrial pressures, and you can see that in this table here. So generally speaking, normal low right atrial pressures would have an IVC of about 2 centimeters with 50% collapse, but as the collapse decreases and the IVC increases, we start to get signs of elevated pressures. Conversely, if you have a very flat IVC that is completely collapsing, that is highly predictive of somebody who is needing more volume. The easiest way to do this is again to use your M-mode spike and go through the liver and IVC just distal to where the first hepatic vein drains into it. And here we can see a relatively normal example of a 2 centimeter inferior vena cava, and with normal tidal volume inspirations is 1.2 centimeters. And I did want to mention that when we talk about the respiratory variability of the IVC, we do mean with normal tidal volume respirations, not the sniff test that everybody likes to do per se. Here's an example of the plethoric IVC in somebody who is probably volume overloaded and heart failure. We see the first hepatic vein is nearly as big as the inferior vena cava itself, and there's not a heck of a lot of respiratory variability. It's totally flat. In somebody who is in a distributive shock state, here we see this is just a normal tidal volume breath, complete collapse of the inferior vena cava with inspiration. And when I put these 3 diagrams next to each other, it's very easy to appreciate the difference between them. All right, moving on. Right ventricular overload and increased pressure is another common reason that my colleagues will ask me to potentially do a bedside echo, is because they're concerned about the patient having a pulmonary embolism. Now, while this is a useful screening tool and at some points has relatively good specificity, it has terrible sensitivity for the risk stratification of pulmonary embolism. So I don't want you to confuse this by thinking that you have a grossly normal echocardiogram and you do not need to pursue the workup of PE any further. That is not the case. But particularly in patients who are hemodynamically unstable, in peri-arrest periods, or if you are trying to determine whether the presence of a pulmonary embolism represents a submassive or massive state, that would be considerations for either a higher level of care or other interventions like thrombolysis. This can be very useful. So this is best assessed in the apical 4-chamber view, and remember the normal relationship between the right ventricle and left ventricle is 0.6 to 1, or about 1/3 of the total width being the right ventricle and 2/3 of the total width being the left ventricle. Now, what that means is that if the ventricles are ever the same size, that's abnormal, or if the right ventricle is larger than the left ventricle, you got to seriously start thinking about this. The other thing to recognize is that the findings may be chronic. And how we usually tell that is by the thickness of the right ventricular wall. If it exceeds 5 millimeters, that typically would represent right systolic pressures that have been elevated for some time because the ventricle has had time to hypertrophy as a result of that. In acute pulmonary embolism, we're going to see an increased size of the right ventricle. We're going to see the septal bowing towards the left ventricle, which you can see both in the apical views and in the peristernal short views, and we commonly refer to this as the D sign. Right ventricular wall hypokinesis with apical sparing is called McConnell's sign. That may come up on boards or on rounds. It is something that is highly specific for pulmonary embolism, but you do not see it very frequently. Occasionally you will actually see a clot within the right atrium or right ventricle itself, and obviously if you see that, that's fairly suggestive. It's terrifying also when you see it bouncing around in there. And then tricuspid annular plane systolic exertion, or TAPSE, is a measure of by how much that tricuspid valve annulus is going to be moving laterally during systole, which will give you sort of a gross estimation of right ventricular systolic function, which is much harder to measure than left ventricular systolic function. So here's an example of acutely elevated right ventricular pressures from a large pulmonary embolism. This is not the Mayo orientation. This does in fact represent the left ventricle on the right side of the screen here, and you can see that the right ventricle is completely overwhelming the pressure of the left ventricle. This is somebody who is in dire need of therapy and at risk of hemodynamic collapse from massive pulmonary embolism. Here's the same patient in a peristernal short axis. We can see that septal bowing now. It's pushing it into the right ventricle, and the left ventricle, and we also gain an appreciation for the relative size of the two ventricles next to each other. So I'm going to put these videos next to each other of a normal heart, both in the peristernal short and apical axes, next to this patient with the massive pulmonary embolism. And we can see now what the difference is between the two of them. Pay particular attention to the septal wall in the short axis view and the relative size of the two ventricles in the apical views. All right, so just wrapping up with a few cases, because I know we've gone over a lot of material. Case 1, going to be a 60-year-old man presenting with 3 weeks of worsening chest pain and dyspnea after recovering from an upper respiratory infection. I did a quick bedside echo, and lo and behold, we actually see a large pericardial effusion. If I recall, this gentleman didn't really have any reason for it. I think it was just chalked up to pericarditis following this viral infection. But this is a very large effusion, and he actually has very clear collapse of the right ventricular wall there that you can see more so on the short axis on the right side of the screen. His inferior vena cava, it's not the best picture in the world, but you can see there it's quite large and it's got almost no respiratory variation. And I did measure the diastolic inflow across the AV valve during respiration, and you can see that it greatly exceeds 25%. In fact, it's almost 50%. So this gentleman did need to go to the cath lab for an urgent pericardiocentesis and did quite well afterwards. Case 2, a 37-year-old woman who's 4 weeks postpartum presenting with respiratory distress and hypoxia. We'll go over lung sonography next month, but for the purpose of this, we can see in the top left corner a parasternal long axis of her heart, and the left ventricular systolic function here, normal, slightly diminished, greatly diminished. Well, this is greatly diminished. In particular, pay attention to the anterior leaflet of the mitral valve there, and you can see there's really not a whole lot of movement at all. When measuring that with our E-point septal separation, we see that it's 19 millimeters, representing for sure an ejection fraction of less than 35%, an inferior vena cava, which is large and has no respiratory variation. And again, we'll go over B-lines next month in the lung sound, but we have a lung that does represent pulmonary edema. So her diagnosis is postpartum cardiomyopathy. Case 3, 79-year-old nursing home patient presenting with excuse me, cough, fever, and hypotension. We have an extremely hyperdynamic heart, a inferior vena cava that collapses completely with normal inspiration, and a lung ultrasound which shows actually consolidation of a lobe. So she is septic from pneumonia. And again, this is all done at the bedside in the first 5 or 10 minutes of the patient being there, or in the first. So case 4 is going to be a 45-year-old woman with metastatic breast cancer presenting with leg swelling, chest pain, and hypotension. We have ultrasounds which show the greatly elevated right ventricular chamber size, large IVC, and a quick DVT study which confirms a clot in the right popliteal vein. Diagnosis, acute pulmonary embolism. And finally, case 5, 73-year-old gentleman brought in by EMS who had an unwitnessed cardiac arrest, and we can see, well, cardiac standstill. So I'm going to conclude for now. For those of you who will be joining us this afternoon in the Sim Center, think of any questions. We'll go over a lot of the applications and hands-on, and otherwise I appreciate your time. Thank you.